Okay. Good afternoon, everyone. Welcome to Comod Cancer Foundation Breast Cancer Talk. In the month of October 2021, this is our second breast cancer event since we actually launched out last year. So I would actually like to say a very big thank you to a lot of you on the platform. And to those that join online, we also thank you because we know that our online traffic has started to move in a very different direction. Today in the house, we have Dr. Dakpo Osinowo, who is a surgeon, consultant general surgeon. I'm not a medical person, so you have to learn to put these things in order. With Lagos University Teaching Hospital, that is, I know as LUTH, and he's also a lecturer at the College of Medicine in the University of Lagos. He has been practicing for well over 15 years, and he's here to talk to us all about breast cancer. The surgery, all of us somehow know a lot about the oncology, but we really don't understand the other parts of it. So today we're looking at the other parts of it because I know I've spent a lot of time on the oncology team. So today is not the oncology, it's the surgery team. Dr. Osinowo, thank you for joining us this afternoon and welcome to the house. I will now take over. While you take over your side, I'll take over the admin of allowing people in.
Yeah, it's actually, I'm humbled, I'm honored, I'm privileged to be talking here today. Good morning, good afternoon, everyone. Good afternoon, everyone. Can you hear me?
Everybody can hear you, but we follow house rules. We don't.
Yeah, so
good afternoon, doctor.
Yeah.
Good afternoon, doctor.
Good afternoon.
Yeah, so this is going to be the good afternoon, everyone. This is going to be the format for the presentation. I'm going to give a small talk on what breast cancer is all about, and then everybody's free to ask me questions. That's how it's going to be. So I'm going to give you a short presentation on what breast cancer is. Just give me.
Yeah, and when you get your questions, can you start putting them in so that I can start sending them forward?
All right.
For Dr. Osinowo to be answering as we go along.
Slideshow. Let me do slideshow. Yeah. Good afternoon, everyone. Again, good afternoon, everyone. Hey, I've been appropriately introduced. So I'm going to talk about. I'm going to focus on. Apparently, I've just suddenly realized I have a worldwide audience, but many things I'm going to say are going to be focused on Nigeria. Be that as it may, it also applies to other parts of the world. And I'm going to start like this. Why are we talking about, apart from the fact that today, October is the breast cancer month. Why are we talking about breast cancer? Because breast cancer is the #1 cause of cancer morbidity and mortality in females in Nigeria. This probably applies to most other countries in the world. It's actually the leading cause of cancer death in Nigeria. Look at the incidence. The incidence is about 53. It's about 60 per 100,000 per year. This from a study done by Global Cancer Observatory in 2020. And breast cancer constitutes about 23% of cancer cases in Nigeria. That means that virtually every one of us here will know somebody who has breast cancer. That is the implication of all these statistics I've just shown you. So I'm also going to talk about the overview. This is the part that is not that's quite disheartening about the situation in Nigeria. Look at the overview of breast cancer in Nigeria, right? When we talk about breast cancer, generally, there are 4 stages. Actually, I'm going to put them as 5 stages. There's what we call stage 0, in which you virtually can't pick up anything in the breast. At best, usually when you do a mammogram, you can see an abnormality. You can have a stage 1 disease, which there's a little lump in the breast. There's a lump in the breast, and the lump is more less than 2 cm. Then you have a stage 2 disease, where the lump is greater than 2 cm, and the patient may also have what we call lymph nodes in the armpit. Then you have stage 3 disease, in which there's extensive disease in the breast. And of course, we have stage 4 disease. which there's metastasis. Stage 3 disease, otherwise called a locally advanced disease. Look at this. For stage 0 disease, we rarely see patients with stage 0 disease. We rarely see patients with stage 1 disease. Stage 2 constitutes about 25%, while the remainder, stage 3 and stage 4, constitutes 75%. This is a huge number. And the thing about stage 3 and stage 4 is, many times stage 3 and stage 4, the best we can offer as doctors or as oncologists is palliative care, right? But I also need to emphasize breast cancer is heterogeneous. It's heterogeneous. The stage 4 disease of one individual may be different from the stage 4 disease of the other individual. But what is pertinent, what is significant here is these earlier stages, stage 0, stage 1, and really stage 2. We really see that because these are the conditions where, these are the stages where the surgeon or the oncologist can comfortably tell you, oh, I'm going to give you a curative treatment. And the other thing you need to know is, what are the risk factors for breast cancer? Also, I also need to emphasize that breast cancer is seen in both male and females. Of course, it's commoner in females. And what are the risk factors? One of the important risk factors are the ones I'm going to enumerate. Family history of breast cancer in first-degree relatives. That means you have a blood relative that has breast cancer. That confers you a risk. With increasing age, you also, if you live up to the older you are, the higher your risk. Of course, you also have lifestyle factors. I'm not going to dwell much on these lifestyle factors much, because they're important, but they're not as important as the earlier ones. The other important thing, all these other ones too are not too important. Younger age at which you saw a period, you've never had children, older age at which you have a first life birth, you had your menses till about 55. They're important, but they're not as important as the family history of breast cancer, or your age, or your gender, or gender in the sense that are you male or female. These are the risk factors. So I've spoken to you about risk factors. At the same time, I need to talk to you about things you can do to mitigate your risk. If you exercise, you don't live a sedentary lifestyle, you are mitigating your risk. If you have children, you ensure your children were breastfed, you are mitigating your risk. Estimated, these are ways of mitigating your risk. However, you need to understand that mitigating your risk is an extremely difficult thing. You can't say, because I did this, automatically means it's not going to happen to me. It's not like that. It's not 1 + 1 = 2. The number of variables involved are a lot more than whether you breastfed your child, whether you exercise. So it's not exactly like that, but you just need to be aware. You exercise, you don't live a sedentary lifestyle, you breastfed your children, it reduces your risk. It doesn't make the risk 0. It doesn't mean you can have it. The other things, so I've spoken about how you mitigate your risk and what the risk factors are and what the important risk factors are. Be that it may, I need to tell you, what are the symptoms of this dreaded disease? What are the symptoms? Usually the commonest symptom many a time is a lump in the breast, right? Many a times it's a lump in the breast. Quite a lot of people ignore the lump in the breast, right? Until the lump is quite, rarely do I have patients that have a lump in the breast that's less than 2 cm. Most lumps are usually greater than 5 cm. By the time a lump in the breast is greater than 5 cm, we are dealing with a locally advanced disease. We are dealing with the stage I spoke to you about. That's a stage 3 disease. The other ones are what we call nipple discharge. The nipple discharge in breast cancer, many times it may be bloody. It could either be expressive or spontaneous. Expressive means it's actually when you press your breast that it comes out, while spontaneous means you see the stain on your bra. There could also be nipple changes. The nipple may be retracted. There could be skin changes. There could be swellings in the armpit, right? There could also be a wound on the breast. You don't want to wait for this. By the time there's a wound in the breast, we're dealing with a locally advanced disease as well. So now that you know what the factors are, what the symptoms are, you also need to know, how do you screen yourself for this disease? There are quite a wide variety of ways in which screening can be done. Of course, unquestionably, we all know that the best mode of screening is you do a mammogram. That's it. But that's not to say you shouldn't do a self-breast examination. You shouldn't do a self-breast examination every month, and you shouldn't have a clinical breast examination done. Unquestionably, bilateral mammogram, especially once you are above 40, you do your mammogram yearly. That's the best way to screen for this disease. Screening, I also need to define what I mean by screening. Screening means you want to pick up the disease before it's actually apparent clinically. That's what screening means. That means if you screen for the disease, that means there's a likelihood those stages I spoke to you about, stage 0 and stage 1, they can be picked up very early. And once they're picked up very early, the patient can have what I call curative treatment. The patient can even have what we call a breast conserving surgery, because it's not every breast cancer case that we remove the breast as surgeons. If the patient presents very, very early, the patient can have what we call the right word is actually breast conserving surgery. The breast is being conserved. It depends on the stage of the disease. It is extremely difficult to say you want to conserve a disease, you want to conserve the breast in a stage 3 disease, for example. You can still do that in a stage 1 disease comfortably, and occasionally in stage 2 disease. But once we talk about the stage 3 disease, the challenge is not even proper to say I want to conserve the breast, because all you want to do is to ensure the patient survives and the disease-free interval is prolonged. So in order for you to ensure that you also mitigate your risk, you need to know a lot about yourself. Many a time you need to know what the normal appearance of your breast feels like, so you can actually notify your healthcare provider if you experience changes such as breast pain or a mass, a new onset of nipple discharge or redness. But that does not mean you should still do your yearly mammogram. You should still do your yearly mammogram, especially when you're above 40. What does the mammogram entail? So the mammogram is just an X-ray of the breast, right? It does not expose you to radiation that will cause cancer, because it's a low-dose radiation. It's a low-dose radiation. It does not increase your chances of having breast cancer, because that question is going to come up. Does doing mammogram increases my chance of having breast cancer? It's a total no-no. So mammography is currently the best available population-based method to detect early breast cancer and when treatment is the most efficacious. And I've spoken to you about this screening for breast cancer. It makes it possible for us to pick up as medical practitioners, to pick up a disease, whether it's stage 0 or stage 1. Occasionally, the mammogram may be supplemented or complemented rather, with an ultrasound. What you also need to be aware, when you go for screening, occasionally abnormalities may be picked up. These abnormalities may need to. The abnormality does not necessarily mean it's cancer, but for us as doctors to confidently rule out cancer, because the only sense of anybody going for screening is, oh, I want to ensure I don't have cancer. If any abnormality is picked up, that abnormality may need to be biopsied. So you need to be aware of that. Screening may sometimes involve taking needle biopsies of areas of abnormality or suspicious areas. That will invariably happen if you go for screening. But it's better you go for screening and pick up an abnormality very early and have it treated promptly. Yeah, basically, when what do we do for breast cancer cases? When it presents to us, maybe there's a lump in the breast, there's a nipple discharge, there's a wound in the breast, any other thing, the first thing as doctors is to take a good history, we examine the individual, we do a mammogram, we do an ultrasound. Unquestionably, of course, we do a biopsy to confirm the disease, to confirm that, oh, we're actually dealing with a malignancy. You do a biopsy, that's what the biopsy does for us, and you get a pathologist to review it. I need to also tell you that breast cancer management is really multidisciplinary, right? You have a surgeon, you have an oncologist, you have a pathologist, you have a psychologist. Quite a number of other people are also involved, but let me just talk about those 3 or 4 things. When we do biopsies at times, when you do biopsies and it confirms that, oh, sadly, it's malignant, we're dealing with cancer, essentially what we've done is, we have the biology of the disease. But for us to give the patient the word we use these days is called a patient-centered treatment, we should also do the chemistry of the disease. That's otherwise the big word for it is immunohistochemistry, right? What the doctors actually, what the pathologist does, they want to know whether the breast cancer has estrogen receptors, what we call progesterone receptors, what we call HER2 receptors. These are just big terms, but they are things you need to be aware of. You should be aware of them, because it's not just the diagnosis of breast cancer that's important. We also need to know the chemistry of the disease. The big term for the chemistry of the disease is called immunohistochemistry, because it will ensure that whoever is managing you will give you a patient-centered treatment. Right. And what do we do for breast cancer? Many a time, the surgery is dependent on the stage of the disease, whether you are removing the entire breast or you are removing a lump in the breast, whether you are removing what we call what I wrote here as lumpectomy, it actually means a breast conserving surgery. That means you're removing the cancerous lump with surrounding normal to you. It's otherwise called a lumpectomy. That means you're removing the cancerous lump with a small margin of normal to you so that you conserve the breast. But I need to emphasize, you can only do that in an early disease. Many a time, patients will require what we call chemotherapy. Chemotherapy in layman's language is to kill the cancer cells already in the blood. Why do you want to kill the cancer cells already in the blood? To reduce the likelihood of future recurrence. We also, in the event if individuals had mastectomy, we usually give radiotherapy as well to reduce the likelihood of recurrence at the site of the surgery. These are the basic things we do when it comes to breast cancer management. You can now realize that breast cancer management is actually multidisciplinary. The surgery is going to be done by a surgeon. The chemotherapy is going to be administered by a medical oncologist. The radiotherapy is going to be given by a radiation oncologist. So it's actually multidisciplinary. It's not just something that is just done by one specialty alone. Sorry. And when there's hormone treatment, if the individual is, like I told you about estrogen receptors, when the individual is estrogen receptor positive, they may need to give them some drugs for about 4 or 5 years to reduce the likelihood of the recurrence. I'm not going to go into the details of that, but some of you guys may know, some of us may know what's called tamoxifen, usually given to reduce the likelihood of a recurrence. It's actually given for a long time. In some cases, it can be given for about 5 years. Or the whole essence of that, you take it every day for about 5 years to reduce the likelihood of a recurrence. Right. This is right. Many a time, look at this small lump, right? This constitutes a stage 1 disease when the small lump is less than 2 cm. When it's less than 5 cm. No, when it's less than 1 cm, it constitutes a stage 1 disease. When it's about 5 cm, it constitutes a stage 2 disease. When it's greater than this, it constitutes a stage 3 disease. The one that is greater than stage 3 disease, those are the things we see in Nigeria, or it will have extended to the armpit. Look at the armpit, lymph nodes in the armpit. By the time it's extended to the lymph nodes in the armpit, many times we're dealing with the stage 3 disease. So you may not be able to offer what we call breast conserving surgery, right? I'm open to questions now. Hello?
Doctor, thank you.
Yeah.
Questions are on ground. Even I have questions. I have questions. So let's start. Please, if you have any questions, start to put them in the chat box, but I'm going to start with one. It says, when the pain comes back in the same breast, what does that mean?
When the pain comes back in the same breast. Yeah, I need to also say something about pain. Pain is not one of the earliest symptoms of breast cancer. But this is if somebody has had cancer already. If somebody has had breast cancer and has having pain on that side of the area of the surgery, that has to be properly investigated. It could be a recurrence. It could be a recurrence to the ribs. Okay, and then at stage 3, and you are told you have 50-50 chances. What do you advise? Do you advise to conserve the breast or not? For stage 3 disease? Yeah. It's extremely difficult to conserve the breast in stage 3 disease, because stage 3 disease means the disease is locally advanced. Maybe the lump in the breast is greater than 5 cm. Usually, we don't consider breast conserving surgery once the lump in the breast is, some people even use 4. Once the lump in the breast is greater than 5 cm, quite a number of surgeons will not offer the patient breast conserving surgery. Okay. But one thing about breast conserving surgery, you also have to factor into consideration the size of the lady's breast. You know, I mean, maybe as I can, whether it's a D, 36D, or the size of the breast, because the only essence of the breast conserving surgery is you still want to leave something that is cosmetically appealing, right? So if somebody has a very small breast and has a 4 cm lump, if you remove a 4 cm lump and what is left is not cosmetically appealing, the question you ask yourself is, worth the while? Because the whole essence of breast conserving surgery is you want to leave something that's still cosmetically appealing. Occasionally, you may need to bring in a plastic surgeon to reconstruct the breast.
Doc, okay, Doc, please, can you put this thing down first so that we can be seeing your face very clearly? This presentation.
How do I do that now? Sorry, I'm coming. Let me exit.
That's it. We want to see your face very clearly now.
Yeah.
This is very serious conversations. Yeah. All right, so the next question I have. If you have a strong family history of cancer, what is the chance of getting another one, and how does this change treatment options?
All right.
Could it be genetic, whatever, you know what I mean?
Yeah, let's talk about somebody that has it. I'm going to give you an example of somebody that I've read a lot about, Angelina Jolie. Angelina Jolie's mom had ovarian cancer, right? Because Angelina Jolie's mom had ovarian cancer, she knew she may have a risk of breast cancer, right? So she did what we call, you do the BRCA1 and BRCA2 gene, and she was positive for the BRCA1 and BRCA2 gene. So anyone that has a family history of breast cancer, it's not just breast cancer alone, breast cancer, ovarian cancer, and lately prostate cancer, aggressive prostate cancer in men has been included. If you have a family history of all this, you should screen yourself for breast cancer, right? You should do a screen, you do a BRCA1 and a BRCA2 gene. So therein lies the issue. If the individual is positive for BRCA1 or BRCA2, then the individual has greater than 80% of developing cancer. So the individual may be offered, some people like Angelina Jolie had prophylactic mastectomy and breast reconstruction. In some centers, they just give them tamoxifen to reduce the likelihood of breast cancer, and they monitor them regularly. So if you want to toe the line of Angelina Jolie, you want to do, you're positive for BRCA1 and BRCA2, and you're ready for a prophylactic mastectomy and breast reconstruction, that's a big thing. You must be ready for that. But I think it's worth a while if you have a family history of breast cancer and the individual has a BRCA1 or BRCA2 gene, it's positive for BRCA1 or BRCA2 mutation.
Okay, now I'm going to be putting questions differently. Okay, the next question I have for you is, please, can you explain to us this HER2 positive, what is that all about? Because that has a specific treatment option.
Yeah. It has a specific, you know, when I was talking about it, I said, we also want to know what we call the immunohistochemistry or chemistry of the disease. Yes. That means you do the estrogen receptor status, the PR. R2, the other name for R2 is human epidermal growth factor receptor. If the individual is positive, they give them what we call monoclonal antibodies. The other name for this is Herceptin or trastuzumab, right? So that is usually given for about 1 year, for every 3 weeks for 1 year. The whole essence of doing that is to reduce the likelihood of a recurrence as well.
Is that for HER2?
Yeah, for R2.
HER2 positive?
R2 positive, yeah.
Okay, can I now take it personal home? I want to take this question back home. Because from my experience, I have ended up with HER2 that metastasized. Okay, so maybe that might be the difference. I don't know. Maybe that makes a significant difference because they never found the breast lump, but they found the metastasis in the brain, which had many, many tumors. And I am not going to ever come off that immunotherapy. I currently take Kadcyla, which you would know. So can you explain that? That's chemistry. I don't get that chemistry yet. I'm not yet on that.
You see, your own situation, I didn't really get it very well. But what is customarily done is if the individual is R2 positive, actually R2 positive can be 1+, can be 2+, can be 3+. The people will usually customarily treat is the 3+. right?
Yeah.
And they give them the drug for customarily a minimum of 18 sessions. That means every 2-3 weeks for 18 times. That's what's customarily done. But if you want to put I don't know what, I'm not very, very comfortable. I'm not very, very sure of what they're doing for you.
Okay, maybe because there's the brain part as well. So okay, maybe because actually they've never found the lump in the breast. So maybe that's why. But I take an immunotherapy. Okay, I get it now. Okay, let me keep going. I think I know now you've actually answered a question I've baffled over a very long period of time. Okay, so let me ask the next question now. Questions are plenty, Doc. You'll be patient for us today. Next question says, I had pus on my nipples earlier this year. The GP gave me antibiotics and asked me to use sports bra. Recently, I noticed eczema between my armpit and breast. I thought I had 2 boils under my armpit, but has now gone. Should I be going back to the doctors?
See, there are 2 things here. Right? I know in England, I mean, for you to see a breast surgeon, you have to probably go through your GP. The issue is, unless you see, I'm really very worried when you see an infection of the breast in a non-lactating woman. If you're not breastfeeding and you have an infection of the breast, that infection must be viewed with great suspicion. It must be treated aggressively. Occasionally, we may need to do a biopsy. I think the individual should get referred to by GPs to a breast surgeon and be properly evaluated. Or unless the individual is a breastfeeding mother and lactating mother, that's when, it's only lactating mothers that we don't treat aggressively their breast problem. And they have a breast infection, because they are the only ones that can have a breast infection. You don't see, breast infection is not common in non-lactating mothers. For obvious reasons, the breast is engorged during lactation, so they can have an infection, right? You can have an infection. But in non-lactating mothers, you have a breast abscess, you have a pus there, it must be viewed with great suspicion and be treated aggressively. And that aggressive treatment is not just, we're going to give antibiotics alone. It may involve taking a biopsy as well.
Wow, that's interesting.
Yeah.
Okay, what are the chances that breast cancer returns, either that same on another breast or where it's been supposedly managed?
Yeah, is it the issue?
Sorry, I'm trying to translate this question.
Yes, I understand that. I understand the question. The only sense of going through the whole gamut of treatment, whether it's surgery, breast conserving surgery, chemotherapy, immunotherapy, and radiotherapy, is to reduce the likelihood of recurrence, right? Recurrence at the site of the original surgery is called local recurrence, right? Recurrence at a distant place is called distant recurrence. So in order to reduce the likelihood of any of these things happening, the individual must go through the full spectrum of treatment. And it's going to be vary from one individual to individual. It's also going to be dependent on the biology of the disease. So let me just leave it that way. It's going to be dependent on the biology of the disease. Because we have some conditions what we call, I'm not too sure whether you've heard about it, we call them triple negative. You know,
yeah. I'm about to ask you a question on that, actually.
Yeah, that is not a particularly good biology, good chemistry. That's not a particularly good chemistry. Individual has that kind of chemistry. That means this has a triple negative disease. That means all the ones we customarily measure, he or she is negative for them. There's a likelihood the individual may have a recurrence. But you also have to appreciate this thing is not 1 + 2. It's 1 + 1.
No. That is a disclaimer. We always say that. There is no fixed rule on the cancer. Because one of the things I've tried to say, and I will say it now again to anybody who's listening, cancer is not. You can't say this is the exact thing that caused it. One of the things you started off with, which actually fascinated me, was the fact that you mentioned that blood test. If anybody's sick and you're actually feeling sick and it just keeps reoccurring, please, even if nothing, that blood test helps the doctors find markers. I think I found out that that blood test really does make a difference on markers. Am I correct in saying that?
Yeah, the immunohistochemistry helps goes a long way when they take a biopsy.
Can I now ask the next one? It says, I had triple negative stage 2 breast cancer. I had a mastectomy. And after the CT scan, I'm clean. But I'm not on any drug. And the doctors have said she should just move on with her life and nothing else, and no other checks have been done. Is there anything she needs to worry about, or does she?
I think the first thing she has to do is, I don't know what, she has a triple negative disease. All she had was a mastectomy, right? Maybe she had a very, very early disease. Maybe
stage 2.
Stage 2. That means stage 2. That means the lump is less than 5 cm. Maybe that's why the doctors left her like that. They just have to watch her.
Okay.
They just have to watch her. Yeah.
So you know, one of the things I always say, because we're talking about our Nigerian environment, so the advice is the person should keep an eye on themselves.
Yeah, they should need to do that.
Okay, what is it that they should do to make sure that they are on top of themselves, though, so that they know, I need to go to the doctor at this point, I need to go to the doctor at that point? Oh yeah, and she also had she had 4 cycles of chemo.
Yeah, she's good. Ideally, she is expected to have chemotherapy. Usually, they give them 6 courses of chemo, 6 sessions of chemo. I don't know why she had 4. I'm not going to dwell on that. But
we're not dwelling on that.
But the thing about it is, any breast cancer survivor sees a doctor forever.
Oh yeah, I know that from people like us.
Yeah, any breast cancer survivor sees a surgeon or an oncologist forever. So you're probably going to be seeing them every 6 months or at least once a year. So it's not like, oh, we finished treatment, we are discharging you, bye-bye. It's not acute appendicitis.
I like that one. Another question goes, younger women under the age of 30 seem to be more younger people being diagnosed with breast cancer under the age of 30. Is there any particular reason, especially in our Afro-Caribbean environment? Because predominantly it's Africa and Nigeria and England.
That's a difficult question. I mean, quite a number of studies have been done. I can't answer that question, right? But there's a possibility they may have a family history of breast cancer, and they may have a BRCA1 or a BRCA2 mutation. You understand that?
That's true. Yeah, I get
BRCA1
that.
and BRCA2 mutation.
Yeah, I get that. Okay, that makes a lot of strength, and that adds up. Yeah, that makes sense. Why stage 4? Please, if you have any question and you actually want to speak yourself, put up your hand and I'll find you. Why is stage 4 different for individuals? I get that question. Some people stage 4. Okay.
Yeah, I know. You see, let me tell you something about breast cancer. Breast cancer is heterogeneous. It's not a homogeneous disease. Stage 1 for different individuals may vary. Stage 2 may vary from different individuals. Stage 3 may vary, and stage 4 may vary. Right? So it's not like it's heterogeneous. There are different types of the same disease, of the same stage. Right? So you can't say, oh, this person has a stage 4. You know, some doctors will just tell, oh, this individual has a stage 4 disease. Oh, something is going to happen to he or she in 6 months' time. It's never like that. Because the disease is heterogeneous. You can't say this is what is going to happen. It's heterogeneous. Right? It's not a homogeneous disease. The stage 4 disease is not homogeneous. It's heterogeneous. There are different subtypes of the stage 4 disease. And we're all different. Our genetic makeups are also different. You understand me?
I'm understanding. I'm understanding you. The next question I have is from a male's perspective now. Males, what are the signs that they have to be aware of to get to recognize they may have something wrong?
The male one is a lot easier, right? Male breast cancer is not very common. The male-female ratio is 1:100 in Nigeria, right? But you're not expected to have a lump in your breast. You're not supposed to have a wound on your breast. So that's relatively straightforward. You're not supposed to have a lump in your breast as a guy. You're not supposed to have a lump in your breast, right?
Oh, okay. So if they see a lump in those areas.
Yeah, they're not supposed to have a lump in their breast. Of course, some men have what we call they call it pseudogynecomastia. They have a lot of fats in their breast, but that's not a lump, right? You're not supposed to have a lump in your breast. So it's a lot easier picking up a lump in a male breast than picking up a lump in a female breast. Because your breast, as a guy, your breast is supposed to be flat.
Okay.
Yeah.
But sometimes can't you think that that lump might be a boil?
Might be what?
A boil.
If it's a boil, investigate it and be absolutely sure it's a boil.
Okay.
Yeah.
Okay. Larry, unmute yourself, please, and ask your question.
Good afternoon, Doctor.
Welcome.
Thank you so much for the information you've just given. My questions are in two parts. Okay, I was diagnosed with triple negative, what you just said. I was given stage 3. I was given the 50% chance of retaining my breast. And the other question was my daughters, I've got all girls. There is no heredity of cancer that I know of in my family, so I'm the first. So, and I was told the R2 was there as well. All this language you're saying, everything seemed to be coming back now. I think I just buried it somewhere. But I just wanted to know, for my daughters, do they need to be checking themselves?
Yeah,
you mean, do they need to be going to the doctors for a specific check? Is that what you're trying to ask?
Yeah. Do they need to take, the BRCA1, BRCA2? Do they need to take that?
I think they should take that. I think they should do that. How old were you when you had a problem, ma?
I was diagnosed at 50.
I didn't get that. How old were you?
50.
Yeah, the 50 is the borderline. I think they should. If they can do the BRCA1 and BRCA2 gene. They can do the BRCA1 and BRCA2 gene. Yeah, they should do that. And you said something about they gave you a 50% chance of,
retaining my breast.
Retaining your breast or something like that?
Yeah, I mean, they did take, what do you call it now? They did take all those.
I didn't get that. I can't hear you clearly.
Sorry, can you hear me now?
I can hear you now, ma. Yeah.
Okay, they did take lymph nodes as well. They took all the lymph nodes on that side of the breast. But they gave me 50-50 of either taking it out or leaving it. And then so that I can have a report. Sorry?
What was done eventually?
They left it because they told me if they take it out, it's the same chances of them leaving it. So I took the other option, which is leaving it.
So the lump in the breast was not excised?
They took out all the cancer and all that bits they need to take out. They did the surgery and everything, but they retained my breast.
All right. There are two things. I can't. I don't know the size of the original lump in your breast. I don't know, because you said they took out everything. It's also critical for us to know, because also tell you there are different types of stage 3 disease, right? You know what the size of the original lump in your breast was. I'm going to assume they removed that as well, and I'm going to assume you had radiotherapy as well.
I had radio. I had chemo.
Yeah.
And then also, I was the one that asked, the pain is just back. And the pain is back in the same breast now. And it's traveling down my arm. But
is it the inner side of your arm? The inner side of your arm, right?
Yes. Yeah.
And that could be from the axillary surgery,
Okay.
the surgery they did in the armpit.
Right.
But how frequently do you see your doctors?
Every 6 months.
Every 6 months. Have you done a mammogram recently?
I just did one 2 days ago.
All right, good. And it was clean?
I don't know yet. I've not got
I
the
think you
result.
need to see your doctors regularly. I need to see your doctors regularly. But the pain in the inner aspect of your arm may be because of the axillary surgery you had.
Okay. Yeah. Okay. I've just had a lot of stuff in between that. I just noticed all the dizziness, all the things that I normally feel. I just constantly back, but I don't want to associate it with anything. So I'm just waiting for the test to come through. Then I take it from there. But
I think you should just take it from there. I think you should just take it from there. Either way, a local problem in the breast won't cause the other things you spoke about, won't cause dizziness, won't cause you're just generally feeling unwell. A local problem in the breast is not going to cause that.
Okay. So, and you know, the treatment you're talking about, is this global? Is this something global, as in, it's not just the way Nigerians treat breast cancer? Because you've talked about stage 3, you've talked about stage 4, and there's some things that you've said that doesn't seem to apply here in UK. So I'm based in UK, so I'm just asking if it's a global thing. Because also when you speak to people in the States, they seem to have a different approach to it as well. So
all right, let me put it to you this way. Breast cancer treatment is patient-centered, right? The way everyone is treated is different, but because it's patient-centered treatment. Just because this individual had this treatment does not necessarily mean you're going to have the same treatment. So it's a patient-centered treatment. It's going to be based on the biology and the chemistry and the stage of the individual's problem. So I can't just give you an across treatment. It's not a blunderbuss. It's not a blunderbuss.
Oh, sorry.
It's patient-centered.
I need to take it down. Thank you so much. Thank you so much.
Yeah.
There's a question here which is to do with Herceptin.
Yeah.
Is Herceptin the only option for a HER2 positive breast cancer, or are there any other options for treatment?
I think
I took Herceptin.
The one that is easily available is Herceptin. The other name for Herceptin is trastuzumab. I think there are newer ones. They are evidently more expensive. They're newer ones, but they're much more expensive. Herceptin is the first R2 drug we had for breast cancer. They're newer ones. They're more expensive.
I took Herceptin. Okay, so let me comment on this question because it's interesting. I took Herceptin and I took trastuzumab. And one of the things, but I know there are two brands. I realized that I still take some parts of Herceptin till today, which is why I get tired when I take chemo. That's what I call the chemo part of it. But what I did realize was the effects are the things that people may worry about. So I'm just trying to advise the person who is asking the question, not to necessarily take it, whatever it is, from what I understand, they're similar, and there's a cost difference depending on how you go. But the drug is still, the central components are still the same, and it's still central to breast cancer treatments. Is that correct? Have I said it correct? I'm not a medical doctor, but because of my, I know how to ask questions at the doctor's surgery. I ask, and my consultant is very patient.
I know a lot about it. If you've been living with a problem for some time, you know a lot about it.
I now know, it's like I'm a doctor, but I'm not. There's another question that has come up. Please, sorry. Some people don't like to put it this, don't like to. Okay. Let me now see the next one. The one that's, if there's anybody else, there's Juliet on. Sorry, Juliet, can I let you come on if you're ready? Sorry. Your hand was absent.
Thank you. Good afternoon, Doctor. Thank you very much for the talk. I was the one who raised the question about younger women getting breast cancer. I have a daughter who is under 30, and she has several friends. Just recently, a friend of hers diagnosed with breast cancer in the last 2 weeks. Aggressively, she's had to have her eggs have just been stored so they can start treatment. But they don't have a lot of these cases, they don't have any history of that BRCA gene you're talking about. They're the first ones in their families to have this breast cancer, that they noticed the lump and luckily went to see a doctor and something's been done. So I was just wondering, I guess that's quite a generic question to say an increase in younger people, because when people talk about breast cancer a lot, you're talking about older women who've had children possibly, and you're talking about mammograms, but they're younger women who haven't even had kids who seem to be getting cancer. And I know you said it's heterogeneous, so it can happen. Yeah.
So the issue is, usually there's already the first person in the family. She's just 30. She may have it. She's most likely, I mean, I expect the doctors, right? Evidently for her eggs to have been saved, I'm sure she's having a comprehensive treatment. They must have checked her for BRCA1 or BRCA2 gene. I don't know whether they did that. They will have done that because she's quite young, right? She's quite young. She may be positive. She may be negative. There's a high chance she'll be positive for BRCA1 or BRCA2.
Mm-hmm. Okay. Thank you.
Any other question?
One more thing, sir. The issue is we don't really know yet. We're not confident why younger people are having breast cancer. We can't confidently answer that question. We can't confidently answer that question.
But then, doctor, shouldn't there be also checks? I mean, because the population that typically have breast cancer might be older women. I don't know. I'm just asking you. If younger people are having it, I guess the breast awareness that people should be checking their breast and all that time should pick up, hopefully. Yeah.
I mentioned that earlier. You need to be aware of the breast. But the thing is, we can't screen people of that age for breast cancer. We can't screen 30-year-old people for breast cancer. There's even people between the ages of 40 and 50, there's even a controversy in some countries about screening them for breast cancer. So talk less of somebody in their 30s. You can't screen them for breast cancer. The best we can do is they should be aware of changes in their breasts.
Mm-hmm.
Okay.
Unless
Can I ask, Doctor,
when breast cancer.
Yeah, when you say you can't screen people, why is that? Is it because you don't see enough people? You're saying you can't.
No, economically, look at it. No, I agree with you, right? You are saying young people with breast cancer, right? But the vast majority of people with breast cancer are not young.
Yes.
So the focus is on the older people rather than on the young.
Yeah, but maybe we need to start changing that psychology in terms of if younger people are getting it. I'm not saying that they have to focus on young people. They should make them aware. Mm-hmm.
Yeah, I agree with you entirely, right? But the only way they can easily be screened for breast cancer is for them to be aware of changes in their breast at that young age. Because you can't say every 30-year-old start screening them for breast cancer. It's not going to work.
Yeah.
Economically, it's not going to be acceptable. It's going to be prohibitively expensive to do that. Because even between the ages of 40 and 50, there are issues in some countries about screening them for breast cancer. Some countries will say it's 40, another country will say it's 50. So
it's 50 here for mammograms. In the UK, I think mammogram starts at 50. That's when I started having mine. Yeah.
Yeah.
Mm-hmm.
So the issue of we're going to screen people, of course, younger people will not do a mammogram, they do an ultrasound.
Yes. Thank you very much. Yeah.
Thank you, Doctor. I've got another question for you, but I want to also ask one question. iPhone, okay, iPhone, go before me. I've got another question, but I've got it written. iPhone, go before me. Unmute yourself. Somebody's name on it is iPhone.
Oh, hello, it's me, Sophia. My question is for the doctor, really. Doctor, you mentioned on the PowerPoint that some of the risk factors, which you said is not really relevant, was contraceptives. So it just takes me back to the previous question, or to the previous person that asked the question about younger women having cancer, breast cancer, could there be a link between women below 30 and contraceptives?
Yeah, see, the issue about contraceptive is what confers a risk is prolonged use of oral contraceptives, and you must have used the contraceptive for at least 4 to 5 years. And the good thing about it is, if you stop, that risk attributable to the usage of oral contraceptives for 4 to 5 years dissipates within 1 year. So that's the way it is. So we're talking about prolonged use of oral contraceptives, and prolonged use it for more than 4 to 5 years. And you're using it every day. I'm talking about using it every day for 4 to 5 years.
Doctor, women at that age, normally, they have all types of different contraceptives. Some have the implants in their arm for 5 years.
The implants don't cause a problem. The implants don't cause a problem. It's the OCPs we are talking about.
I see.
Yeah, that's what we're talking about. The one you swallow every day.
Okay, pills.
Yeah, that's what we're talking about. I'm not talking about implants.
My people perish due to lack of knowledge.
I'm telling you. Thank you.
Thank you for that question. Wow, I've learned a new one. Implants. Okay, let me go on to the next one. The next one says, I'm rounding up. So if you have a question, please quickly ask the question. The next one now asks that if for someone who has breast cancer, what is their guided pathway?
Yeah, for anyone.
So I think maybe the person is. I think they're trying to say there might be a suspicion of them having breast cancer. So
all right, good. So the clinical pathway is this: if you're suspected or you think there's a problem, I don't know where you are.
Nigeria.
Nigeria, in UK, right? You see
Nigeria.
First,
the person is in Nigeria.
Right? You see a doctor first. Yeah, you should see a doctor. I mean, what I mean by your doctor is not you should say surgeon. Ideally, you should say surgeon, right? Most ideally, a general surgeon. Then general surgeon will examine you. If there's something there that they need to do an imaging of the breast, an imaging will be done. If there's something to be biopsied, it will be biopsied. That's the pathway.
Okay, that's a very good one. Is there anybody else with questions? Because I am coming to the end of this segment. Okay, and my own last question for all those that are going through cancer journeys. One of the things that has always come up that is very heartbreaking, especially for us Afro-Caribbean people, is we do not go. Data is now showing that we are at higher risk of death because we do not follow the awareness. We don't. Is that what they say? Is that how they say it? But Black Afro-Caribbean people are late. What do you call it? Late
presenters.
Yeah, that's it. I'm not a doctor now. They're late presenters. And I can say that because my consultant in the UK, not the one in Nigeria, the one in the UK, has said, when I was talking about this program, she said, we need you to talk to Afro-Caribbean people around the world because they are late presenters. And by the time they come, they are quite late. That we are limited with what we can do with them. How do I get through to such a set of people to go and seek that guidance, especially in Nigeria? In Nigeria, I've done the radio show, I've done the television, but I need to get this message across in Nigeria. What would be your suggestion?
Yeah, my suggestion is what we are doing now, for example, right? We talk about it, right?
Let's talk about it.
Not be like, we talk about it. It should not be stigmatized. And the other thing we also have to realize is, the individual has not done something wrong. You've not done anything wrong. In the fairness, you've not done something wrong. That's why you had the disease. You didn't do anything wrong. So for you, your children, your family, you need to be aware of what is going on, right? You need to be aware. You don't say, oh, like the way they say in Nigeria. I don't know whether the Afro-Caribbean say it like the way they say, it's not my portion. You know, in Nigeria, they use the word.
No, they still say it here.
They say it there. All right, good.
Yeah.
I mean, nothing is, you can't say it's not my portion without not doing something about it. You just don't say it's not my portion. I don't do anything about it. You don't go for a mammogram. You don't do a breast ultrasound when you're at the required age. You see a lump in your breast. You don't do anything about it. You keep saying it's not my portion. No, it doesn't work that way. I think the first step we are doing is talking about it, and we ensure it's not stigmatized, and we also ensure that whoever has it has not done it. I mean, the individual has to be aware that he or she has not done anything wrong. It's just a roll of the dice. Then put it that way. A roll of the dice.
I want to thank you very, very much on behalf of the entire Common Cancer Foundation team for this fantastic, awesome presentation of breast cancer for us, because you hit a lot of things, and the last thing you said, stigmatization, was a very big thing, because I don't think any cancer person, Afro-Caribbean, that I know yet has not gone through the stigmatization race, including myself. And some of us have chosen that whether or not we're stigmatized, we will make noise about it. So I want to really thank you for honoring us, for allowing us for agreeing to come on Common Cancer. We will be coming back to you, you see, for the fact that you even are happy to even talk with us. Some people will not talk to us, so they say we're too small, but you agreed to come to talk with us, and we really appreciate it. Really appreciate your time.
Okay.
Gosh, I don't know what to say, because all I can hear on this platform is, how do I
But how
find
can they
a
get
doctor?
the
Thank you for an excellent doctor.
Just take one down.
I don't know. I don't want to say honored and humbled.
That's all I'm getting here. Then thank you, doctor.
How do we get in touch?
Thank you. My Oga.
Do you really think? Let me call Nana.
My Oga, you were talking to us. No, I don't think he realizes his device went on. Okay, so I want to say a very big thank you to you and to the house. You can unmute yourselves now. Thank you for joining us on Common Cancer Foundation. Next month, we'll be looking at pancreatic cancer, and we'll be sourcing for someone who will talk to us. We are also now live on AIT twice a month, and we will be bringing Dr. Osinowo onto AIT Live Common Cancer Foundation awareness sometime in the beginning of next year, to come and talk to people in Nigeria again about our awareness program. If you want, follow us on Common Cancer Foundation. You can find us on YouTube, Facebook, Instagram, and send us an email. And if you need help, if you need support, if you need guidance on where to seek help, please don't hesitate to talk to us. We'll get back to you. And if you want to see Dr. Osinowo, I will send you his
office address,
his office contact, and you can actually book an appointment to get in touch with him and see him in the clinic. Yeah. So I want to say thank you very much. Thank you, everyone. Thank you, Dr. Osinowo, for joining us today. We really had, I cannot even lie. I'm sure that we will have a lot of posts on our Instagram page to post to share facts. Seriously. Bola S, do you want to say something? I don't think so. I was just looking for somebody's trouble on this. I don't know who it is, but yes, everyone, you can log off now. Thank you for joining us, and we'll see you soon. I'll send out the post for next month in the next few days. Take care. Have a lovely afternoon. Dr. Dakwa, I'll call you.
Thank you,
Dr. Osinowo.
Thank you so much.
Take care, everyone.
God bless. Thank you.
Thank you.
Wow.
Thank you.
Thank you, sir. Thank you very much. Thank you, Denise.
Thank you.
Thank you.
Denise, I will call you. Make we talk.
I know.
Okay, let me log off. Then you can just talk.
Wow.
Thank you so much for this.
Madam
Bye.
Lasisi, I'm seeing you tomorrow. Bola,
Yeah,
oh, now you
I
baby.
know.
Okay. Yeah, we thank God. Jesus is Lord.
Amen.
Madam Dr. Donyolo.
Hello, ma. We have to
Hello,
talk
sir.
briefly.
My
We need to
colleague in
talk
crime.
briefly.
We need to talk. We need to talk.
Tomorrow now. I will see
I'll
you
see you
tomorrow.
tomorrow.
Okay, okay. And I'll talk to you later also, Denise. With just one thing I need to mention.
Okay. I'll call you in a minute.
Okay, no problem.
Take care of yourselves, everyone. Hawa, thank you for joining. Sarah, thank you for joining. I am about to log this off and end it.